This explainer is based on Postural Orthostatic Tachycardia Syndrome, POTS, a vestibular physician's deep review of diagnosis, pathophysiology, and management, published by Australian Dizziness Clinics.
Welcome back to the final module in our series. Today, we're getting into the absolute nitty-gritty of POTS. You see, POTS sits right in the middle of several other orthostatic syndromes, and to treat it effectively, you've got to be absolutely certain you're treating the right thing. If you get the differential wrong, well, you're treating the wrong disease. But if you get the prognosis right, you give a really frightened patient genuine, evidence-based hope. So here's our roadmap for today. We're going to quickly run through separating out those orthostatic mimics, looking at the long-term prognosis, tailoring our care for adolescents, navigating the tricky waters of pregnancy, and finally building a rock-solid relapse prevention plan. All right, let's jump straight into separating the orthostatic mimics, the rule-out phase. We really have to start by acknowledging the diagnostic peril of orthostatic intolerance. The crucial thing here is paying close attention to the hemodynamic response. By definition, POTS and classic orthostatic hypotension are mutually exclusive, right? OH is defined by a sustained fall in blood pressure within 3 minutes of standing. Specifically, we're talking a systolic drop of 20 or a diastolic drop of 10, and crucially, it lacks that compensatory tachycardia we see in POTS. Basically, it's either a heart rate spike without the pressure drop or a pressure drop without the compensatory spike. Now, what's really fascinating here is how we distinguish POTS from another incredibly common presentation we see all the time in clinic, vasovagal syncope. If you do a tilt-table test, VVS shows its hand through a vasodepressor mechanism. We're looking at a concurrent fall in blood pressure, which is very often accompanied by a later bradycardic faint, and that is the exact opposite of the tachycardia predominant pattern we're looking for with POTS. This brilliantly illustrates what we like to call the differential fan. Take a look at inappropriate sinus tachycardia, for example. The key giveaway there is that the tachycardia is present even when the patient is lying flat. Or what about spontaneous intracranial hypotension? If your patient comes in with an orthostatic headache that completely resolves within minutes of lying down, you absolutely need an MRI with gadolinium to check for brain sagging. And of course, there's pheochromocytoma, which can perfectly mimic POTS with paroxysmal hypertension. You're going to need a 24-hour urine catecholamine test to rule that out. And before we even think about finalizing a POTS diagnosis, we've got to run a full blood count to exclude anemia and check thyroid function for thyrotoxicosis. Also, let's address the elephant in the room, anxiety. Because POTS disproportionately affects young women, it has this incredibly frustrating history of being written off as psychosomatic. While panic disorders do produce hyperventilation-driven tachycardia, they do not produce that true isolated orthostatic heart rate increment you see on an active stand test. Sure, anxiety often coexists, but it rarely explains the whole picture. Okay, moving on to the long-term prognosis, looking ahead. So, having safely ruled out those mimics, what exactly is the trajectory for our patients? Well, this timeline gives us some fantastic evidence-based hope. With solid non-pharmacological management, things like exercise reconditioning and aggressive fluid loading, international registries actually show that between 60 to 80% of patients achieve meaningful functional improvement within just 12 to 24 months. Fast forward to 5 years, over 50% of patients no longer even meet the formal POTS diagnostic criteria. That's especially true in cases with a post-viral onset. But, and this is a big but, we have to balance that positive long-term outlook with profound empathy for their current day-to-day reality. Look at this quote from the literature. Quality of life impairment in POTS is severe and comparable to congestive heart failure. Just think about that. That is a staggering metric. While we know they're likely going to improve over months and years, we absolutely must validate their current suffering and actively track their symptom burden at every single clinic visit. Next up, tailoring care for adolescents, where we have some distinct thresholds to keep in mind. We're pivoting to our special populations now, starting with our teenage patients. That number you're seeing is critical, 40. For patients aged 12 to 19, the diagnostic threshold actually shifts to a sustained heart rate increment of 40 beats per minute or more upon standing. Why the change? Because teenagers just naturally have higher autonomic reactivity. Plus, adolescents often won't even complain of palpitations. Instead, they'll present with severe nausea, abdominal pain, and an outright inability to attend school. The really great news here is the adolescent prognosis. 60 to 80% of teenagers will see total resolution or at least significant improvement within 3 to 5 years, largely because they quite literally just grow out of it. Because of this, structured exercise reconditioning and shared school accommodation plans are the absolute cornerstone of management for this group. We really want to hold off and be very conservative with pharmacotherapy here.
Let's shift gears and talk about navigating POTS during pregnancy.
This second specialized population requires some incredibly careful navigation. This timeline perfectly illustrates the wild fluid dynamics of pregnancy. In the first trimester, progesterone acts as a massive vasodilator, which increases venous pooling. So frankly, your patient is going to feel much worse. But as they move into the second and third trimesters, they get this amazing natural boost in their circulating blood volume, which very often dramatically improves their symptoms. However, postpartum, that plasma volume is rapidly lost, which unfortunately means a very high risk of an acute symptom relapse.
The biggest hurdle during pregnancy, though, is the medication. The heavy hitters we usually rely on, fludrocortisone, beta blockers, midodrine, they all carry significant Category C or D risk designations for the fetus. This means you must mandate a pivot to enhanced non-pharmacological strategies. We're talking heavy fluids, salt, and compression, and you absolutely have to coordinate a dedicated joint review between obstetrics and cardiology. Finally, let's talk about the relapse prevention plan. Actionable exits. Because POTS fundamentally follows a relapsing-remitting course, you cannot just discharge a patient without an exit strategy. Before you finalize that discharge, you need to sit down and clearly explain the common relapse triggers. An ordinary viral illness, a week stuck in bed, a major stressful life event, or even just a summer heat wave. These are going to cause symptoms to flare up. Patients really need to understand that these setbacks are completely expected. It doesn't mean their disease is progressing or that they're back to square one. Discharge every single patient with this non-negotiable relapse prevention checklist. Number 1, maintain that aerobic and resistance exercise conditioning. Don't stop moving. Number 2, keep up the strict adherence to the high fluid and salt loading protocols. And number 3, early re-engagement of these non-pharma tools immediately after a setback occurs. Giving a patient this roadmap is huge. It shifts them from feeling like a helpless victim of a malfunctioning nervous system to being an active, empowered manager of their own long-term stability.
This has been an Australian Dizziness Clinic's Vestibular Physician Review. Visit australiandizzinessclinics.com for the full literature review and clinical cheat sheet. As you head back to the clinic and reflect on these protocols, ask yourself this: how many of your historically anxious or treatment-resistant patients might actually be misdiagnosed mimics, or perhaps just going through an entirely expected, manageable relapse? I'll leave you to think about that. Thanks for joining us for this series.